next case is 60-year-old male with ward-off necrosis. The patient underwent ERCP due to CVD stone 2 months ago at other institute. Post-ERCP pancreatitis occurred and was treated conservatively. The patient presented to clinic complaining of fever and abdominal pain, and the CT scan revealed ward-off necrosis. The patient was scheduled for EUS-guided drainage. We give the floor to Dr. Hawes and Dr. Itoi in the OR.
Okay, well, good morning to everybody. This is, as you heard from Takao Itoi's talk, this is a very difficult problem and one that should be solved by a multidisciplinary kind of effort. For me, I am extremely pleased to have people around me to help me make decisions in this particular case. So Stefan is here, Norio is here, Horst is here, Takao is here, and we're all putting our heads together. If we can go to the X-ray, I just want to...
X-ray?
X-ray?
We see it.
Okay, so if you can scan up just a little bit, this is, the transducer is well down in the duodenum. And I wanted to hold this position to show you the pathology, but I just wanted the X-ray to show you that we're sort of in the third portion of the duodenum. And as you can see, we're sort of looking laterally. So now if you can turn to the ultrasound view, you can see here that something is here. And as you scan back and forth across it, it took us a little while to convince ourselves, but probably there is a wall around it. And you can see these bright echoes here within it, which is suggested that this is sort of a collection of material. And again, you got a little bit of a hint of a wall around it. We can measure this if we want, and it's about 5 centimeters in its sort of biggest diameter, about 4 centimeters in its biggest diameter. So we think this is the fluid collection, and if we can, do you want to give the contrast now?
Yes.
So we debated whether or not this was a fluid collection, and I don't know if the audience sort of understands this, but to me, this is sort of obscure. I mean, do you know definitively that that's a fluid collection and not just some interstitial inflammation? And I think it's obviously, it's an important differential to make. So at Takao's suggestion, we're using contrast. We're using some SonoView, and we were going to see if indeed this tissue or this area here is perfused or not. So I think the SonoView is going in now. Is that
okay?
Okay, perfect. Thank you.
Right. Around the 20 seconds, the bubble reached the pancreas, surrounding area. More, you can see a bubble now, from now. Oh, yeah, here.
Okay, so now you can see the wall of this lighting up. Okay, do you see that? There's a little bit of sort of a blood flow, if you will, within this lesion corresponding to this area here. But this area here is completely devoid of any bubbles. So,
yeah.
So actually, I think another benefit, which Stefan just mentioned, is that while I measured this from here all the way down to here, in fact, there's some perfusion here so that this may in fact be viable tissue, making this even smaller, maybe about 3 centimeters in diameter, rather than the 4. Now, Takao made a good point that from this cross-sectional perspective, it may be small, but we know from the CT scan that it tracks down to the pelvis. So, although at this particular point it may be relatively small, there obviously is a bigger fluid collection to drain. So this is a really, really important point. From a technical standpoint, this has a wall around it. We've debated about this, but Takao feels strongly that even though this sort of has a tissue appearance to it, it's more fluid, sort of pussy, thick, gelatinous fluid, as opposed to actually necrotic chunks of tissue. You can see here that there's a reasonable wall here. There's a very short distance between the gut lumen and this fluid collection. We can put flow on it, and flow's important because the duodenum is very, very well vascularized. And Takao had mentioned that they've seen really significant bleeding in doing these duodenal drainages. So that's something to take in mind. But I think technically we're likely able to get into this area with a double pigtail catheter, dilate the tract, etc. The question that we've been debating is really whether we should do that. And it's critical, I think, for the audience to understand this aspect of things. Just because something is technically feasible, is it the right thing to do now? What we've learned is that he's afebrile, and that his CRP is only about 10. He's not visibly ill. There's no impingement on the bile duct. There's no impingement on the GI tract. His pancreas, actually, which I'll show you if we have time, is actually fairly normal, and his pancreatic duct is intact. This is all peripancreatic necrosis here. So if we drain this, then we will, by definition, infect it. So bacteria will get into it. If we ineffectively drain the bottom part of it, then there's certainly a chance for infection. So the question is, why not wait? Does waiting create any problems? Does it burn any bridges? Or does it potentially make things better? And I think the consensus opinion, I think, is that if we don't have to do this now, that it would be better to wait. That over time, this will more liquefy. There's a little bit of a chance that it could actually undergo reabsorption. And at any rate, it should be easier the more mature it is and the more liquefied. So let's have the discussion. Takao, you disagree?
Finally, I follow you. However, in my experience, this kind of the huge wound, soon they become infectious, symptomatic wound. That's why we keep the root endoscopically first, and then the internal external drainage and the lavage rinsing the watch. It's I guess much better. Looks solid, but actually just concentrated pass sooner I guess become infectious. But finally I follow you. Should we vote?
The one thing that
Yeah?
we've seen the CAT scan, there's extensive collection connecting to the pelvis.
Mhm.
Yes.
If we wait, I have the experience that those pelvic fluid
Mike.
can be isolated because it gets smaller, so there's no access in the future.
Exactly. We experience same thing.
Yeah, so if you wait, probably pelvic fluids need to be drained percutaneously.
More difficult.
So my guess would be that the necrosis in the pelvis is going to need to be drained percutaneously either way. But your argument is that it will get walled off and lose its access from this area?
From
Is
this
that-
current
And they become decompression here around here and cannot do at that time the percutaneous the transduodenal puncture
You cannot
because
do
they are
it.
more smaller, but still infection remain.
But you know,
we were also, I was in the guidelines group for necrosectomy from the HGE, and the point is in this case, I think there's a clear guideline that the patient has no symptoms and no inflammatory parameters. So if we have a complication now in this procedure, we have to argue the other way around. And for sure, we can have potential findings in the future, but I think for the moment, there are more pros to wait and see, and to make a
Watchful waiting.
Yes, watchful waiting. In 4 weeks, let's do the inflammatory parameters again. We know now how it is possible endoscopically, but I think we are more on the safe side also for the patient.
Yes, I agree with Takao's opinion, but the procedure after puncture is very, very difficult, I think. So I recommend them to transport this patient to Takao's hospital.
So, I mean, it is important, and that was a point that I wanted to make to the audience from the very beginning, and that is that this is only the beginning. If we intervene today, it is only the beginning of a potentially long process that does require very sophisticated and good interventional radiology to support, potentially require surgical support, etc. So it's important that the audience understand that the initial drainage is only the beginning of a process. And I think that, again, it's a philosophical issue. I think in the United States, for the most part, we're conservative. So we sort of use the same kind of argument that that Stefan used. If he's stable now, there is probably not very much downside to waiting. Maybe, as Norio mentioned, maybe there is. But if you have a problem, if we have massive bleeding or some sort of a complication from this drainage, then it's only speculation that you would have had trouble if you waited, and probably the balance of evidence suggests that it may be easier if you wait. All indications are that you give this as long as it possibly can to mature and to resolve on its own, I think.
Okay.
I think we should also know if the patient is under antibiotics, huh? Because then in this case I would finish the treatment with antibiotics and wait, because otherwise he will quickly develop a severe infection. Huh? Is he under antibiotics?
Yeah. Already. Antibiotics.
But then I agree with you. Then if you finish the treatment, then we will probably develop fever, and then we have to intervene. Huh?
Yeah.
So now we have time to contemplate a vote.
Is there any comment from audience or question?
Yes. Can you wait? Yes, we have a question from the audience.
Okay.
So my question is there any concern as well in terms of the wall of at least what we see in terms of it being not quite mature as well, in terms of, again, increased risk of complication in terms of draining something where the wall isn't so mature yet?
So I think Takao mentioned that the wall seems to be reasonably mature on the CT scan. That's number one. Number two is it has been 8 weeks since his episode of pancreatitis. So time-wise, it would predict that the wall is there. But your point is also well taken. The more mature the wall, the more solid the wall is, then the safer the procedure. But I think it's the consensus amongst all of us that if we don't do this, it's not because we think that the wall is not mature. The CT scan suggests that it is. Time-wise, it suggests that it is. If it matures more, does it make it a little bit easier and safer? Yes. But also to your point, if there is not a mature wall, then you should avoid drainage at all costs. It's really only under exceeding emergencies that you drain something that doesn't have a wall on it, for sure.
Thank you. Thank you very much for this important and educational discussion. We have to move to